now move into the carbohydrate absorption. So the big picture first is you have the lumen of this gut, and that's where you have enterocytes, and these enterocytes then lead into the blood, right? So only monosaccharides are formed here. We have the glucose. You can see the glucose or galactose here, and then we have the fructose and the galactose here, right? So this is the enterocyte, right? This is the enterocyte cell, and we have this basolateral membrane, we have the apical membrane, and this is basically the lumen of the gut, right? Now, can you see that only monosaccharides, glucose, galactose, and fructose are absorbed by the enterocytes? Now, this is the enterocyte. This is the apical membrane of the enterocyte. And you have the glucose and galactose coming in using the SGLT1, and you have the fructose coming in using the GLUT5, right? Um, so you have all these monosaccharides coming in here. They're being absorbed by the enterocytes through the lumen of the gut. And now glucose and galactose are taken up by the SGLT1, sodium dependent, this one. And fructose is taken up by a facilitated diffusion by GLUT5. So you can see that here. All are transported to the blood by GLUT2. So all three of them come here. Glucose or galactose and fructose come here, and then they're transported to the blood here using the GLUT2 transporter. So the SGLT1 here, this is secondary active transport, right? Let me just write this down here for you. So this is secondary active transport. The SGLT1 is doing secondary active transport. And why it works is it depends on the sodium gradient, right? So the sodium and glucose enter together. The sodium and glucose are entering together. And that's why when you have dehydration states and you drink the ORS, which has a little bit of salt, the sodium helps the glucose to come inside, right? So this is secondary active transport. It depends on sodium gradient. Now we have GLUT5 fructose. This is where you need no sodium, right? This no sodium is needed here. This happens by facilitated diffusion. So the fructose is entering by facilitated diffusion. No sodium is needed here. Now on the basolateral side, the GLUT2 brings in all sugars. The glucose, galactose, and fructose exit via the GLUT2 into the blood here, right? This is a common exit pathway for all three of them. Now, the engine of sodium potassium ATPase is important. Why is this important? The sodium potassium ATPase engine takes three sodiums out in exchange for two potassiums inside. And this is basically what is this? This is an ATP dependent this is an ATP dependent mechanism. This sodium potassium ATPase, it takes three sodiums out and gets two potassiums inside. And why is this important? It maintains low sodium inside the cell and it drives the SGLT1 function because the SGLT1 is dependent on sodium. So this sodium potassium ATPase drives this function, right? So remember when we do the oral rehydration therapy with the ORS, the glucose and sodium are given together because they're absorbed by the SGLT1. Water follows and hydration improves. Even in diarrhea, this works. Now we have a test called this D-xylose test. This is a simple sugar test. What happens is that the D-xylose is passively absorbed in the proximal small intestine. It's absorbed directly. The D-xylose is absorbed directly. It needs no enzymes. So whenever there's decreased blood or decreased D-xylose in the blood or urine. So for the D-xylose test, this is simple sugar that is passively absorbed in proximal small intestine. Blood and urine levels decrease with mucosal damage. Since it's absorbed directly, no enzymes are needed. So whenever you see a decreased level in the blood and urine of this D-xylose, you know there is intestinal mucosal damage. It's normal in pancreatic insufficiency, but if there's any intestinal mucosal damage, it's decreased. So it helps to differentiate between the celiac disease and pancreatic problem, which is a normal absorption mechanism. I'll just put that stamp it here so you can see it. So whenever you have a celiac absorption problem, you will see that it's decreased. But whenever there's a pancreatic problem, the absorption is normal. So it helps you differentiate between the two. Then we move on to the vitamin and mineral deficiency problems. Now, this is classic high yield where things are absorbed in the gut topic, and let's go through it one by one. So, vitamin and mineral deficiencies absorption by site. First of all, let's look at the duodenum. Now, the duodenum I told you has the intrinsic factor being absorbed. Also, the iron ferrous 2 positive is converted, 3 positive is converted into 2 positive, and the 2 positive is being absorbed here, right? So the ferrous 3 plus state is converted by the to the ferrous 2 plus state here in the duodenum through the stomach acid as we studied, and then it's absorbed. And the intrinsic factor is also absorbed, and some part of the magnesium is also absorbed. Now, this is regulated by the hepcidin in the liver. So whenever you have increased hepcidin, there is increased iron absorption. So look at this here. We have the Fe3 plus converted into the Fe2 plus via the stomach acid, and the DMT1 transporter absorbs it into the enterocyte. It's stored as ferritin or exported via ferroportin into the blood and regulated by the hepcidin in the liver, right? Now, moving on to the calcium. So this was regulated by hepcidin in the liver. Moving on to the calcium absorption. Now, calcium absorption needs vitamin D, which is the calcitriol, and that is done under active transport. So we've worked on the intrinsic factor and iron. We now move on to the jejunum. Now, the jejunum is the main absorption zone. It absorbs the carbohydrates, proteins, lipids, and most vitamins. So the carbohydrate absorption includes the glucose and galactose and fructose, which are all coming in from the GLUT2 transporter. If we come back to this image on the ferrous being the Fe2 plus being absorbed and stored as the ferritin regulated by the hepcidin, remember that whenever you have duodenal disease or a bypass, you have a decreased iron and you have microcytic anemia. Whenever you have bariatric surgery, you have decreased acid and there's decreased Fe3 plus to Fe2 plus conversion. Now, folate is also important. When we come and study folate here, what happens is folate is a polyglutamate form and it's absorbed from the brush border enzymes. So we can look at folate here. It's in a polyglutamate form. It's absorbed from the brush border enzymes and it's converted into the monoglutamate form. Then it's absorbed in the jejunum and then it's converted to the THF form, and that is the form that the body uses. It's the active form. So whenever you have a jejunal disease or a celiac disease, for example, there is folate deficiency. And a short bowel resection would also lead to a deficiency in folate, and it will cause megaloblastic anemia, even though there will be no neural symptoms. Now, that's something about folate. Folate is absorbed in the duodenum and jejunum. Something about the vitamin B12. It's absorbed in the terminal ileum along with bile salts and requires intrinsic factor. So the vitamin B12 requires the intrinsic factor. Look, it's absorbed in the terminal ileum and it needs the vitamin, it needs the intrinsic factor. So if I look at this entire pathway, I'm going to post it up here for you. Look at the B12 pathway. So there's food in the B12 in the food is absorbed with the stomach acid in the stomach. It binds to the R protein. It's called haptocorin. And then the duodenum, the pancreatic enzymes remove the R protein. And now this B12 that was first attached with the R protein and in the duodenum, the R protein was removed. Can you see that the R protein is removed in the duodenum and the B12 is attached with it? So the B12 binds intrinsic factor and travels to terminal ileum, right? So look at the B12 here. The B12 is attached with the R protein here in the stomach, and the intrinsic factor is absorbed, is made by the parietal cells here. So in the intrinsic factor and B12 attached with the R go on to the duodenum where the R is removed and the B12 and intrinsic factor are combined. This now travels to the terminal ileum, and in the terminal ileum, the B12 and intrinsic factor complex are absorbed through the QBAM receptor, right? So if there's no intrinsic factor, you're going to get pernicious anemia, and you get through that. If you have no intrinsic factor, you get megaloblastic anemia and neurological defects. But in the terminal ileum disease, if there's Crohn's disease, you get decreased B12 absorption and you get decreased bile salts and there's fat malabsorption. In pancreatic insufficiency, what happens is you can't remove this R protein. So the B12 is not freed. Okay, so you have issues with whenever this B12 and intrinsic factor pathway is disrupted, you have issues with pernicious anemia, you have terminal ileum disease. That's also when you get decreased B12 absorption, and also in pancreatic insufficiency, you can't remove the R protein. Now, sometimes you have a small bowel disease, and that leads to a small bowel resection. When this happens, you have whenever the duodenum is gone, you have reduced iron. When you have the jejunum gone, you have decreased folate. And when you have the ileum gone, you have B12 and bile salts both removed. Now, sometimes in bariatric surgery, what happens is in bariatric surgery, you can make the stomach size smaller. And this reduces acid, it reduces the intrinsic factor, and it also reduces mixing with pancreatic enzymes. Now, the result will be after a bariatric surgery, the result will be a decreased iron, decreased B12, and sometimes also decreased folate. Now, something called as the dumping syndrome. The dumping syndrome is something that happens post gastric surgery. What happens is that there is no stomach control because gastric surgery has happened. So there's rapid emptying into the small intestine. This causes hyperosmolar enzyme. A hyperosmolar enzyme leads to fluid shifts into the lumen. So early in 15 to 30 minutes, there's diarrhea, abdominal pain, tachycardia, and hypotension. But late 1 to 3 hours, there's rapid glucose absorption, there's an insulin spike, and then there's hypoglycemia. So this is the dumping syndrome. The dumping syndrome causes rapid gastric emptying and osmotic and insulin effects, right? So if there's hypoosmolar foods, often sugar moves too quickly from the stomach to the small intestine, typically occurs after stomach or esophageal surgery, and then after the insulin spike, you get hypoglycemia. Now we move on to the Peyer patches. The Peyer patches basically are the ileum immunity hub. So let's call them something. Let's call them the ileum immunity hub, right? So here we have the ileum immunity hub. What are they? They're basically aggregated lymphoid nodules in the ileum. And they're part of the gut-associated lymphoid tissue, which we call the GALT. And whenever we get H. pylori, there is a very high chance of getting a GALT lymphoma, right? Don't get lost here. I'm going to post what I said here. So they're aggregated lymphoid nodules in the ileum. They're part of the gut-associated lymphoid tissue, and they're located in the lamina propria and the submucosa. I'm going to post a picture of that here so you can see it more clearly. So let's put a Peyer patch here. Look at the lumen, look at the villi, look at the glands, look at the lymphoid nodules. Oh, this picture is too big. Let me make it the size of something we can arrange here. Here we go. So that's a Peyer patch, that's a germinal center, and that's a lymphoid nodule. So you can see it here, right? So that's a really good picture of a Peyer patch. And what do we know about it? So basically, it's located in the lamina propria and submucosa, and it's a gut-associated lymphoid tissue. What happens is that the epithelium with M cells leads to lymphoid follicles that have germinal centers. You can see the germinal centers here. This gives you B cells and T cells, right? Now, this germinal center, this is a lymphoid follicle, right? And then we have B cells and T cells here, and there's plasma cells in the lamina propria. So these are specialized epithelial cells. These M cells, this epithelium with these M cells are specialized cells. What happens is this M cell samples any lumen antigen. So in the lumen, any antigen comes up, and this M cell samples it, samples the antigen of the bacteria or virus, and then delivers it to the immune cells below in the germinal center. So here we have the immune cells of B cells and T cells. And what happens next is an activation cascade. This is an immune activation cascade where the antigen is presented to the T cells, and the B cells are activated in the germinal center. The B cells then give the plasma cells, and the plasma cells then produce IgA. The IgA is the star of the show. It's the immunoglobulin A, it's the intra-gut antibody. And what happens is that the plasma cells produce the IgA and transport it across the epithelium, and this becomes the secretory IgA. And then this is released into the gut lumen, and then the IgA fights it off. So the function of IgA is that it's neutralizing the pathogen, it's preventing the bacterial adhesion, and it works without causing any inflammation. That's the main thing. And it's very important because the gut must stay tolerant, right? So it neutralizes the pathogens, prevents bacterial adhesions, works without causing the inflammation, and it allows the gut to stay tolerant. The most important thing is whenever a person gets typhoid fever. Have you ever heard of typhoid fever? Whenever a person gets typhoid fever, it invades via these M cells in the epithelium. It targets the Peyer patches. And what it does is it causes necrosis and ulceration, and that leads to bleeding and perforation. So typhoid cells go and attack these M cells mostly. Then sometimes we have a selective IgA deficiency, and that leads to decreased mucosal immunity and increased infections of the GI and respiratory area. And then something called Crohn's disease. Whenever we get Crohn's disease, the terminal ileum is affected. Peyer patches are involved in immune dysregulation, right? So let's go back and read what we have here. These are unencapsulated lymphoid tissue. We call them gut-associated lymphoid tissue. They're found in the lamina propria and submucosa of the ileum. They contain specialized microfold M cells that are attacked by the typhoid fever cells that sample and present antigen to the immune cells. The B cells stimulated in the germinal centers of the Peyer patches differentiate into IgA secreting plasma cells, which ultimately reside in the lamina propria. The IgA receives protective secretory component and is then transported across the epithelium to the gut to deal with the intraluminal antigen. Think of the IgA as the intra-gut antibody or the ileum immunity hub, right? That's something. Let's end here.